Okay. Okay. So I'm glad that you're joining us on the live Q&A for psychiatric nurses who are preparing to take the ANCC exam. Now, Tiffany has already told me that she's planning on taking the ANC nurse practitioner exam, but she wanted to sit in on this because she has some questions about the theorists, which overlap with both exams. So that's totally fine. But the focus of this is mostly for RNs who are preparing to take their board certification exam. It is June 24th. It's 1 p.m. Looks like we've got a couple of people we're going to admit in here. And what I'm going to do is I'm going to record this and then I'm going to post it on my YouTube channel. The YouTube channel is easy to remember. It's PMHRN. That's it. You punch that in, you'll find all the rest of my YouTube videos that I've had there for a long time. So what we're going to do is I'm going to open it up in just a minute, but I have a couple of things I want to say first that are from some questions that I got that are that kind of help frame everything. The first is preparing for this exam feels so overwhelming. If you had to choose one thing to focus on, what would it be? And Tiffany, this is relevant to you just like it would be for anybody taking the RN exam. You have to think of these exams as having basically two components that you have to have working together to do really well on the exam. The first is, of course, what I would call the content, whether it's medications or whether it's diagnoses or whether it's how to do what motivational interviewing is or what DBT is and all that stuff. That's the content of the exam. And that's specific to the exam that you're studying for. And that just takes lots of studying time. The second component that's, I think, equally important is, and I'll tell you why in a second, is the test taking skill of these exams. And I say that it's equally important because I have seen some very experienced nurses who had a pretty broad knowledge base about all different kinds of topics within psychiatric nursing, go into the exam and not really know how to take the exam and ended up failing. I don't want anybody to freak out about that piece of news. 80% of the people who take the exam pass it. So it's a very fair exam. It's a very, I think, representative exam. It's very well written, very clear, but it is really important to get good at taking the test itself and learning how to think about these test questions. So if there was one thing that I would say to focus on, it isn't one piece of content because there's like 70 or 80 different topics to get familiarized with in order to take the exam and have all the bases covered. But if there's one thing, it would be taking practice questions, doing lots and lots of practice questions. That's really important for us, a few reasons. And by the way, it doesn't have to be all new practice questions all the time. I have found that people who take the same practice questions, as long as it's a pretty big pool, take the same practice questions over and over again, get the same rhythm. They learn the rhythm, they learn the style, they figure out how it is that these test questions are being thought about and created by the test question writers, okay? So if I was going to recommend any single thing for you to do, it would be take lots and lots of practice questions written by someone or by an organization that is familiarized with this exam particularly. There are some big companies out there that crank out test questions for like 40 or 50 different exams. I don't find those test questions to be ANC relevant all the time. So I would recommend that you, first of all, use the ANC website and go to the ANC website and go through their practice questions, right? Make sure you have those. And then there are some practice questions that are out on, within the APNA, you can get some stuff through them. And then there are some books on Amazon that have test questions specific to this exam as well. And the more you practice taking these exam questions, the more comfortable you'll be coming in and knowing how to not only accurately read the test question, but then to see how it is that they've organized the answers, not organized like ABC, like the way in which they're organized on the page. I just mean the kinds of test answers that they're giving you, and you'll be able to at least start ruling out 2 and sometimes 3 of them right off the bat, because you've become really astute in understanding what it is the test question is asking. So if I was going to suggest one thing to do, it's do test questions, lots of them. It's really, really helpful. Also, it helps to reinforce the material, the content itself as you're going through. So that's the first thing. The second thing is, and I've had a couple of people ask me this, what theorists should I be reading up on? Which is what Tiffany and I were talking about just at the start of the hour, that half hour. And I think it's what strikes fear in most of our hearts, because it's so dry. And it's not something that we pay attention to when we're on the unit, right? If we're taking care of patients, we're really not thinking about Bowlby's attachment theory. So it's not something that we come across on a regular basis. And it seems like there are so many theorists to study. So the first thing I want to tell you are the theorists that I think are the most focused on this exam. Freud, a little bit, and I'll talk about what in Freud's constructs you need to pay attention to in a minute. But Erikson, absolutely. Piaget, absolutely. It's good to understand and know that John Bowlby is the guy who talks about attachment and the importance between the initial caregiver and the child, and the way in which that sets up the child's psychology for the rest of the child's life. Harry Stack Sullivan, because Harry Stack Sullivan's work is about the relationship between the caregiver, or I should say the provider, and the patient, the therapist and the patient. And that laid the groundwork for Hildegard Peplau, who's the mother of psychiatric nursing, because her work was based on Harry Stack Sullivan's work. So it's good to be familiar with that. Again, in none of these cases do you need to be writing a master's thesis kind of knowledge on them. You just need the basics so that in a test question, you'd be able to discern what it is that they're getting at, or what the focus of the question really is. We're going to talk about Abraham Maslow separately, and he's really important. And I think that's basically, let me just double check. Well, Aaron Beck, everybody should know that Aaron Beck was the father of cognitive behavioral therapy, and to be familiarized with cognitive behavioral therapy. And Marshall Linehan, I've seen a test question on Marshall Linehan's work with dialectical behavioral therapy. She's the one that designed that, just like Aaron Beck designed cognitive behavioral therapy. And dialectical behavioral therapy initially was designed to help borderline personality disorder patients modulate and manage the extreme swings in emotion. And so that's, if you know those things, that'll be really helpful. So let me just review these, and then we'll do sort of an open Q&A. Let me pull these up and see if I can do a screen share. Hold on a second. Screen share, where is it? See, I'm new at this part. Oh, share screen. Okay. And let's do Maslow first. All right. The reason that I want to make sure that I spend a few minutes on Maslow is that Maslow's hierarchy of needs is what the test questions are secretly referring to when they give you a test question that says something like the nurse's priority action in this situation would be which of the following, or the most important thing for the nurse to do next is. If you get a question using that kind of language, you should immediately start thinking about Maslow. And here are the two things to remember about Maslow when it comes to this exam. Not when it comes to, you know, passing the NCLEX where they expect you to know all 5 of these. But for psychiatric nursing specifically, it's really important to pay attention to the first 2 levels, physiological needs and safety needs, okay? Because when you're thinking about patients that come into psychiatric care, we're really not dealing with patients that are having a lot of love and belonging crises without these other 2 being higher priorities. And we're not usually getting involved with esteem or self-actualization. Those are important things to know in his construct. But as far as the exam test questions go, the 2 that you're going to get most on are physiological needs and safety needs. So here's the best way to remember them. Let me tell a story very quickly first, and then that'll make sense. So I'm working in a hospital. We get a call down. I'm working on the inpatient unit. We get an emergency call down in the ER. We go downstairs as a team to see, because there's some sort of psychological crisis going on. They call that kind of code. We go down and there's a woman in there, and then the ER nurse is really put out. This patient won't cooperate with us. What is the problem? She won't take her clothes off. Well, first and foremost, don't even get me started on trauma-informed care on that one, but okay, she won't change into a gown. All right, and then I asked the patient, can you tell me what's going on for you? Well, what finally came to pass is she had been asking the nurse for something to eat because she's homeless and she hadn't eaten in 2 days. And the nurse wanted to do what was on her checklist, right? She wanted to make sure that she had all of her ducks in a row and that this patient was going to get into her gown so that they could do the tests that they needed to do. So when you're looking at Maslow's hierarchy of needs, this patient's physiologic need was trumping all the other things going on for her. Think about it. When you're in this exam, let's just say, and you have a splitting migraine, right? You're having a physiologic need that you're having experience of pain that is going to blot out your ability to function normally. If you were in a situation where your bladder was so full of urine that it was going to burst, you can't problem solve in situations like that. So physiologic needs have to be taken care of first. The next is going to be safety. On a psychiatric unit, when we're talking about caring for psychiatric patients, the easiest way to remember this is keep them alive, keep them safe. And the third of love and belonging would be care, okay? Keep them alive, keep them safe, and then care about the patient. So when you're looking at a test question that's talking about the priority nursing action, first thing to do is look at the test question and say, is there anything in this test question that is threatening the patient's physical well-being, the physical safety, not the safety, the physical continuation of life? Is there a vital sign that is way out of whack? A PO2 of 79? Is the lithium level 2.4? Is there something that is going to put the patient's viability of life at risk? Okay, no matter what else is going on, that is going to be the priority nursing action, is dealing with that. The second would be, okay, there are no vital signs, no other things that are going on that are threatening the patient's life. Cardiac system is fine, respiratory system is fine, patient is alert and oriented. Okay. Is there something that's going to threaten the patient's safety? That would be the next most important thing, and that'll be the priority nursing action in a test question if there are no other physiologic needs that need to be addressed. Okay, so if you get test questions with that kind of language, first thing you need to think about is Maslow's hierarchy of needs. Keep them alive, keep them safe, and care. Okay, so I wanted to make sure we covered that. The next one that I want to cover is, let's see, window is closed, share screen, is Erickson. Here we go. All right, so Erickson, I'm not going to go through my whole PowerPoint. I just want to show you a couple of things. When we talk about the developmental stages in Erickson, the first is birth to 1 year old. So I want you to remember this little baby, and the experience of the baby is focused on with no ability to fend for herself, with no ability to obtain food, obtain warmth. Does she get those things met in her mind magically, automatically, so that she can just trust that the world is somehow, some way magically going to take care of her and in that very initial stage? So it's really about trusting that the world will be okay for her to be in, that when she's cold, something warms her. When she is hungry, something feeds her. So those are the fundamentals, the very first. If that doesn't happen, all kinds of cascading problems already between the ages of birth and 1 year old begin to happen. Doesn't mean that they're not reversible, that they're not correctable, but that's Erikson's idea. Oh, and by the way, I want to make sure, as we're going through these, you may think that in this day and age, the developmental stages should have different ages in them.
Weird. Accept call.
Oh. That we have a different sort of structure in this day and age. Remember that the test questions are only focusing on what Erikson thought the ages should be, not what we think they should be or what might make logical sense. The second one is toddlerhood. This is about autonomy versus shamed out. I always had such a hard time with these terms because I think they're so academic. They don't really help. So when we're talking about a toddler's autonomy, we're talking about, if you watch a 2-year-old, they are in motion. They want to explore everything around them. They want to taste, they want to touch. So a toddler picks up a play block, right, at a daycare center. And in order to find out what it tastes like, toddler sticks it in his mouth. Now, if somebody comes over and goes, wow, that's not something we do. We can't do that here. Things don't go in our mouths here. They're dirty, right? Toddler goes, oh, okay, won't do that. Or I'll do it again and see if somebody else has a different answer. But there isn't the thing of shame or doubt when they get that as a response. If what they get is a scream or a slap, or they get a volatile reaction, being called a name or something, what are you doing, you dummy? That kind of thing. All of a sudden, the toddler is not sure, because the toddler has no way of knowing that that would be something they shouldn't do. Now, doubt and shame begin to creep in. So that begins to set up a lot of potential for some anxiety. One time isn't going to do it, but a persistent experience of that's a problem. You get to 3 to 5. Now, again, you got this term, initiative versus guilt. What they're talking about here, again, I hate these terms. What they're talking about is a kid that's exploring and kind of going out past their normal comfort zone. They're interacting with other kids. They're mastering language. They're exploring the playground. They're doing all these other things. And can they do that without being somehow thwarted all the time, where they're being told that what they're doing is bad, yeah, I think the word would be bad, is what they're doing bad. And that can create a sense of guilt about who they are, what they're doing, and angst. So that's young, what he calls the young child, 3 to 5 years old. 5 to 12 is the older child. We get into adolescence after 12. So 5 to 12 is the older child. They call this industry versus inferiority. I want to slap my forehead when I hear these terms, right? So forget the word industry. What we're really talking about here is an increasing sense of competence in being able to do the things that they're required to do in school and at home. So can they increase their sense of competence, and are they mastering tasks and language and understanding, or do they get the message that they are not able to do those things, that they are not very coordinated in gym class, so they're a klutz? Are they not very good at math, so they're stupid, or whatever versions of that? That's what Erikson is getting into when he talks about the older child. Competence versus the feeling of being incompetent and therefore inferior. The next is 12 to 20-year-olds. Really, this is identity versus role confusion. That's pretty straightforward. We've all dealt with adolescents in one way or the other. We all kind of know what their gig is. We've all been them. So I'm not going to go into a lot of a lot of that. And then young adult, he claimed, was 20 to 35 years old. I think in today's world, we'd say those numbers are different. Intimacy, that is to say, developing friendships and being able to connect with people versus the feeling of isolation and being alone in the world. And then 35 to 65 is considered midlife. I'm happy to know that I am still just barely in midlife. That's good news for me. Generativity versus self-absorption. This is actually a group of my husband is the guy all the way over on the right. And this is a group of colleagues that he does a broadcast with every year for a charity. And generativity is really about having been part of the outside world and feeling that they've contributed and that they are productive and participatory in the outside world, as opposed to just looking at one's own needs and one's own ego, right? And then the last is 65 and older. This is actually a picture of my parents. My dad is now just about to hit 92. He doesn't look any different than he did in this picture 3 years ago. That's my stepmom. She's, I think, 84 now. And this is about integrity versus despair. Do you feel that you've lived a sort of a 360-degree kind of life, or is there this feeling of loss and despair and sort of a disintegration of ego, not disintegration of body? That's a part of it, but a big part of it is just maintaining a sense of understanding the life cycle, basically. So that's I think the best way for me to cover Erickson. I will send out, if you guys send me your, because I don't want to tie up all this time on just theorists. If you guys send me your email address, I will send you the PowerPoint on Piaget and Bowlby so that you have it. My email address is very easy. Alison, ALISON, at PMHRN.com. So drop me a line saying, yeah, I'd really like that handout. I'll send it to you. All right, so let's open things up a little bit. And does anyone in the group have a specific question that they would like to ask right here and now? I've still got more stuff people have asked me, but if you have something, I'd rather give you the floor. Any questions? No? Okay. Oh, Suzanne?
Actually, I do have a question, Alison,
Sure.
about medications. Is there like a certain focus that we should be looking at, or are those questions more just generalized across all diagnoses, all different types of classifications and whatnot?
I'm glad you asked. Actually, it is kind of focused. It's the medications that we come across on a regular basis. It's going to be antidepressants. It's going to be the medications that treat bipolar disorder that are sort of loosely called mood stabilizers, right? Lithium is really technically the only mood stabilizer. The others are, of course, anticonvulsants, but they come under the broad umbrella of that, knowing those drugs. And of course, the first generation and second generation antipsychotics. It's really important to know that the first generation antipsychotics were there to treat the positive symptoms, and second generation antipsychotics have been much more effective at treating the negative symptoms. And I'm going to explain that in just a second. Positive symptoms, this is how I always teach it when I'm teaching nursing students. Positive symptoms are symptoms that are present and shouldn't be. Negative symptoms are symptoms that are not there and should be. Let me give you an example. Hallucination is present, but it shouldn't be. Like normal functioning, it's not supposed to be there. That makes it a positive symptom. Negative symptom is really what we would call anhedonia, or one of the absences of emotion, absence of engagement in socialization. If that's supposed to be there in normal, healthy life and it's not present, that's a negative symptom. So first generations they were dealing with the most florid symptoms like hallucinations, paranoia, those kinds of things. Very effective in treating those, but not in a not treating the negative symptoms, which meant that the patient was still really lacking a big part of normal existence. So along come second generation antipsychotics, and they do a much better job of treating both. And for those who are nurse practitioners or who are physicians, you know, they get really good at the nuance of what drug is going to do the best with what combination of symptoms. For our purposes, for the RN exam, we don't need to know those kinds of things because that's outside the scope of nursing practice for us. Those kinds of things are knowing what a positive symptom is, knowing what a negative symptom is, knowing that the first generation antipsychotics, what the names of those are. And by the way, my exam had all the common company name. So instead of calling something, they were using terms like Haldol, not haloperidol. Now, I don't know if other exams are getting the generic terms and not the regular, the more commonly formulary terms, but that's was my experience. I was surprised by that. So I can't really advise you as to whether you should know both the brand name and the generic, but you should be at least familiar with the brand names, if nothing else. And then as far as any other medications, I don't think so. I can't come up with anything offhand. It's the antidepressants and the full group of them. So tricyclics, the SSRIs, the SNRIs, the MAOIs, but gosh, I don't know why they keep testing us on those. I don't know if anybody uses them anymore, but somebody is going to have a test question on the MAOIs and what foods the patient shouldn't eat. By the way that I always remember that is MAOIs. If you're on an MAOI, you shouldn't eat the foods that you typically would eat at a tailgate party. So beer, wine, brats, hot dogs, those kinds of things that have a lot of nitrates and things like that in them. That's the stuff that I always, as a rule of thumb, there are other things as well, but that's the rule of thumb for that. And then just knowing what the side effects, for instance, with tricyclics, even in the RN practice, we would know that if we were to do a medication reconciliation on a patient who was 75 years old and they were taking a tricyclic, we would want to report back to the doc, did you know that they're on a tricyclic? Because tricyclics are contraindicated in patients who are elderly because of cardiac irregularities that TCAs can cause. Those kinds of things would be good to know. The basics of these side effects that can happen, for instance, tardive dyskinesia that can happen with, particularly with first generation antipsychotics. What are the early signs of tardive dyskinesia? Because a question about early signs and symptoms of that would be a typical question, testing on it, looking at what would a nurse need to do if they saw these symptoms? Well, if you see these symptoms, it's tardive dyskinesia, and that's a medical emergency. You've got to do something right away to get that patient the intervention. And in most cases, you got to send them to an ER. I think that's it. Neuroleptic malignant syndrome as a side effect of the medications. The big thing with second generation antipsychotics is that it causes the metabolic syndrome, and that's pretty basic. The extreme weight gain, changes in their blood sugar, things like that. I think for medications, that's the basics for RN level. Suzanne, does that help?
Definitely. Thank you very much.
Good, no problem. Anybody else have any questions? All right. So I had one that was saying, in a sentence or two, can you summarize what trauma-informed care is? I got to tell you, I sat through when I first started learning about trauma-informed care, we had this specialist come and give I think a 2.5 hour lecture on trauma-informed care. And at the end of it, I just sat back and turned to my boss and went, well, that is just much ado about nothing. I don't mean that trauma-informed care is nothing. It's like she turned it into a 2.5 hour presentation when I can boil it down pretty succinctly. Trauma-informed care is care that is provided to a patient with the understanding that the likelihood is that the patient has experienced trauma prior to their arrival in our hospital or in our clinic or wherever in our care, and that trauma is likely to influence their behavior in how we interact with them and how they interact with us. That's pretty much it. So if you really understand post-traumatic stress of any variety, and my background was in military psychiatry. So when I'm thinking about a female soldier who's been discharged out of the Army and she's coming in because she's severely suicidally depressed, right? So she's being admitted in, she's maybe 38. So she was discharged out maybe 5-6 years ago. And I'm looking at a female soldier who's got severe depression and suicidality. Well, I'm going to be very careful in doing what we would sort of colloquially call a skin check, right? Which is really a safety check to make sure there isn't any contraband coming in. But I'm going to make sure that she understands what I'm doing ahead of time. I'm going to make sure that she has absolute privacy, that her gender preference is in the room with her. If she identifies really more as male than female, and she's more comfortable having a male in the room, then that's what we're going to do. All of those things are really trying to customize the things we have to do as clinicians to provide safe care to her and everybody else on the unit, with the understanding that she may at any given point experience a trigger, and we want to do everything in our power to minimize the chances of those triggers. There are some very obvious pain points, for lack of a better term, along the process of admission for patients that have trauma. At any given point, a homeless woman coming into a unit has, at some point in her life, has probably been sexually assaulted. We want to do a skin check on her very carefully with lots of explanation, asking for her permission, explaining why we need to do this, with as much support, empathy, and clarity as possible, so that she feels as safe as possible, so that we minimize the chances of reactivating her trauma of having been likely sexually assaulted in some way. So trauma-informed care is just keeping in our minds that this patient may have PTSD, and something we are doing that's automatic in our line of work might actually be very upsetting to them. We want to minimize, as an organization, not just as individual nurses, but as a whole organization, we want to minimize those potential triggers. That's it. That's the sum total of trauma-informed care. I know you've said, and we've only got just a minute left. I know you said this exam tests us on critical thinking skills. I don't know how to prepare for that. Any advice would help. Okay, so that's my last question for the day. This is taking a really complicated subject and turning it into something very understandable. Critical thinking skills are what detectives use all the time. So just think of yourself as Sherlock Holmes. We collect information, we figure out that there is a problem, we're trying to figure out why that problem has happened, and then we try to solve the mystery. That's it. That's critical thinking. So when you're looking at a test question, you want to figure out what's in that test question that's important for you to know, what kind of illness it's pointing to, and then what you're supposed to do about it. That problem-solving process is critical thinking. It's not more complicated than that. All right, we are just about up with time. Thank you all for coming in. Don't forget to email me. I'll send you out that other information. Have a great day. Talk to you all soon.
Thank you.
You bet.
Thank you.